I'm Dr. Derek Lee. It's my pleasure to introduce Dr. John Braun, who's a pediatric spine and scoliosis surgeon from Massachusetts General Hospital for Children in Boston. Welcome, Dr. Braun.
Thank you, Derek. It's a pleasure to be here.
Really appreciate you taking the time to make time for the interview, and I'm looking forward, really excited to talk about anterior vertebral body tethering with you, your forte.
I have been involved in this for a while, yes.
Okay. Before we get into that, though, I'd like to backtrack a little bit. Can you talk a little bit about when you first became interested in medicine and a little bit about your career path in terms of actually becoming an orthopedic spine surgeon?
Sure. I'll try to be brief, but there's probably a lot of details that I will spare you. But my family has been in medicine, and my father is a transplant specialist, and so I always had in the back of my mind that I would potentially go into medicine. But for many years, I was not very serious about it. When I got serious, I decided halfway through college that I would stop my swimming career, which was taking 6 hours a day, 6 or 7 days a week, and really focused on, trying to prepare myself for medicine. And got into a very good medical school at Cornell, and didn't know exactly what I wanted to do. I had an interest in neurology because Cornell was very good. They had all the best neurologists. But that field changed a lot with the introduction of the MRI. And I happened to be exposed to the Hospital for Special Surgery, which was right next door to Cornell, part of Cornell. And it just fascinated me how innovative and how impactful orthopedic treatments had become, really in that same time frame. So I was lucky to go to Cornell Medical School. I was lucky to be exposed to the Hospital for Special Surgery. I wound up going there for my orthopedic residency. And then I got a really good fellowship in scoliosis and spine surgery at the Twin Cities in Minneapolis. And all of those sort of formed in different ways my interest, not only in scoliosis, but in innovating.
I'm glad you brought up your fellowship at the Twin Cities, because I believe it gave you the opportunity to look at both pediatric scoliosis and mature spine scoliosis as well. Was that one of the turning points for you in terms of your career?
Yes. So, there are a lot of different people who do scoliosis surgery. Orthopedic surgeons tend to do a lot of it. Some of those are pediatric surgeons. Some of those are adult surgeons. There's neurosurgeons that now do scoliosis surgery, but my fellowship at the Twin Cities really did everything. At that time, there was a private hospital there called Abbott Northwestern that was the busiest spine hospital in the country. So we had neurosurgeons and orthopedic surgeons, but it was a really in-depth experience in pediatric and adult spinal deformity. And there are some people that do scoliosis, but may not be, do scoliosis surgery, but may not be sort of a global spinal deformity surgeon. So my exposure and my, education there and my training was really the whole breadth of spine surgery. And scoliosis was a big part of that, both in kids and adults.
So you would say that that was one of the catalysts for perhaps looking at alternatives to fusion and looking at non-fusion surgery techniques?
Yes. And I can actually tell you the patient that did that. So when I was a fellow, I was involved in a number of research projects, and one of them was looking at sacroiliac joint fusion, which is kind of an odd thing in a deformity, world. But I met a patient who had had a scoliosis surgery back in the 1950s by John Moe, one of the most famous, scoliosis surgeons around. And she did well for 30 years. So think about that. Any study that would have looked at her success at 5 years, 10 years, 20 years, 30 years would have said, we cured her scoliosis. And after 30 years, she had an area of breakdown below her fusion. and wound up having a surgery to address that. And over the next 10 to 20 years, she had 40 something surgeries. And just to make you understand, these were by all the most famous spinal deformity and scoliosis surgeons. So Bradford, Winter, Lonstein, Ogilvy, Denis, the burst fracture classification guy. So a lot of people took care of her and did a really good job, but she had this biomechanics problem that couldn't be solved, that she kept breaking down more and more levels in her lumbar spine, and eventually had a fusion to her pelvis. And everybody thought, awesome, the problem is over, her entire spine is fused and we're done. And unfortunately, that's not what happened. So she then, the next adjacent segment problem occurred in the sacroiliac joints. And so her spine was fused all the way down to the bottom to her sacrum, and she disassociated her pelvis, her ilium from her sacrum. And she had an unstable pelvis. She had several attempts to fuse her pelvis across the sacroiliac joint, which failed. And she was the nicest lady and miserable every day, and said she would never have another surgery. And so what that taught me, and it gets back to treating adults and pediatric patients, is that things that you do in children have an effect many, many, many years down the road. And the reason I got interested in alternatives to fusion was that case. It wasn't to do a minimally invasive surgery. It wasn't to do, a flexible tethering so somebody could do gymnastics. Those are awesome things. And it wasn't to preserve growth and motion. It was really to control the scoliosis in a way that somebody wouldn't have the potential for these catastrophic problems long term. So.
No, that's a great story, because there's often an event or incident that that triggers innovation of some sort, or people looking for options that are better than what's working at present. And I think this segues into vertebral body tethering a little bit, in terms of, was it really just an idea, the concept of tethering, an idea on a napkin sometime in the early 90s that triggered everything?
I wouldn't say the early 90s. So I finished my training at the Twin Cities in 1995. And right around that same time, Jim Ogilvy, who was one of my mentors and the faculty at the Twin Cities, was starting to experiment with stapling of the spine. And, a staple is a tether. It's just not a ligament or flexible tether, right? Mm-hmm. And he did a few patients after I'd left. And I started tinkering around with the same idea and began developing an animal model. And this is all between, say, 95 and 98. And what happened is I ran into Jim Ogilvy at an academy meeting, and I asked him to look at a study that I was going to do in an animal, with an animal model for scoliosis, to look at a staple, just a stainless steel staple. And he had a shape memory alley staple that he was developing with Medtronic, but had nobody to test it. So we had a nice relationship that we developed around that, where I basically took that device and did all the preclinical testing and basic science work. That then became available and was, Randy Betts then had an interest in using that at the Shrine Hospital, and really spent, about a decade looking at the value of a staple for giving you a tethering effect in the spine. Now, in 1997 and 98, we were really interested in looking at the staple, because that was the only thing available. In 99, I knew that the staple was an okay device, but that it wasn't the best device. It was a little bit rigid. You couldn't really squeeze the spine down and get correction, and it toggled and loosened over time, even though it had a shape memory component to it. So in 1999, I put a stake in the ground and said, tethering is the way to go. And I had an invention in 1999 that, basically I licensed to Medtronic, a big company, At that time, we looked around, there was nobody else that had anything in that space. And we developed a relationship and had the goal of bringing this device to market through a standard FDA IDE approval. And you may know that that is the gold standard for testing a new type of device. And we were ready to go with that in 2001. So way before anybody else, we had committed to not just the idea of tethering or maybe a staple or maybe a cable, but we had put it down on paper, and we had a whole system, and we're ready to go from there. And there's a whole nother story of how Medtronic handled that, but
yes, I've read some postings on that. So that invention, that device, was the actual original tether itself, the cord or ligament that I've seen referred to in your research?
Yeah, so we tested lots of different things. When you create a patent, you can have very specific things around one idea that you think is the best. And then there's a number of other different versions of that. So, we tested sort of as an homage to Randy Betts and others using staples, 1, 2, and 3 staple constructs. And we tested straight ligaments and loop ligaments and straight cables and loop cables. And the idea was to get as much information as we could about these devices. We did it in a way where we would compare devices head to head, so we'd get some idea which one was better. And we also did it in a scoliosis model where there was a scoliosis that was actually getting worse, just like in adolescent idiopathic scoliosis. So I still think to this day, there isn't anybody else who created a progressive scoliosis model like we did, and then tested devices head to head against each other in that model. A number of testing scenarios were just a straight spine to see if you could create a deformity. So I think from early on, we were trying to get an idea of what device would be the optimal device. And so the tether we're using now it's a very reasonable version of things, but it's sort of a screw straight tether. And one of the interests we had early on was a little bit more of an anchor device and a loop tether, but it was all under the same umbrella of a flexible construct, spanning disc levels.
Absolutely, and I'm going to talk to you about tethers in the future of this interview, because there's so much interest in it, right? What's coming down the pipeline. But I would also like to go back a little bit into your basic science research, your animal models, and your preclinical testing as well. Because did you know in your heart that right away the tether was the way to go? Because I know you looked at the alternatives with Dr. Wall with a plate, Dr. Betts with the staples, Dr. Newton with the cables, but you also looked at dynamic static loading in terms of its impact on bone growth modulation, and you saw that there was maybe about a 50% improvement in bone growth modulation with a dynamic tether, right, as opposed to something more static. You basically you went about proof of concept with all your data over time, correct? And that's basically the process that needed to be followed.
So there's a lot of ways to answer this question, but I do think if you have to have a lot of luck in picking certain things, and then you have to have a lot of stubbornness to kind of get through testing them. And some of that can be crazy because you might have an idea that's never going to come to fruition. But I do think that throughout this whole thing for 25 years, I've really just tried to stick to principles. And if you really try to stick to basic principles of orthopedics, of medical care, of basic science and testing things, and then bringing them, to patients, I think you do a lot better than if you get too far ahead of yourself, sort of guessing or trying to prove something without really a good foundation. So I think the thing that taught me the most was developing an animal model, which was really hard. Nobody had a large animal model. And that means an animal model that approximated a human in size. There were smaller animals, or there were very destructive models, but we wanted a model that mimicked idiopathic scoliosis. So right off the bat, idiopathic scoliosis means there's no cause, no known cause. Mm-hmm. So you're trying to create a model for something for which there is no cause, which is tricky. But we sort of thought we understood the biomechanics enough that we could create a reasonable model. And I think basically creating that model taught us a lot. And then trying to, figure out everything we could about the staple really gave me a huge background in understanding how these devices might work, didn't work, what the drawbacks were. We saw a lot of things doing that study. And even though Ogilvy was my mentor, at the end of that study, I knew a lot more than probably him about them, because we put in thousands of staples in different scenarios. And, handing that data to Betts so he could start, get it through his IRB and do that, we had caveats that were like, look, this is a very reasonable device. It's safe. It's effective. We just don't know how effective. And I think Betts, over the course of about 10 years, learned that the staple could be effective in certain scenarios, but probably wasn't going to be very effective over 35 degrees. So that's about what we would have expected from our animal data. So, it was at the end of doing that staple work, I just thought you could do a lot better. I mean, the staple doesn't really attach to the bone the way you would like. And it loosens. And I think one of the reasons Betts had some success with the staple is he happened to put the staple in right at the right time to modulate growth before it loosened. But if it went in too early or too late, or it loosened, before it was needed, then you had all these confusing. So we thought you really needed something that held its fixation to bone. And we thought that you needed a flexible construct, because you wanted to protect your attachment to bone, something that absorbed forces, like a staple. The whole thing toggles every time you move. And so it would loosen, it could break, it could back out, but it wasn't going to give you the long-term effect that you wanted. And you couldn't squeeze it down and get correction the way you would want as well. So the staple was a great thing to start with, but it, after we spent a bunch of time with it, the staple was kind of telling us, there's a lot of room for improvement.
Which I noticed with one of your presentations, and it's interesting that because you wanted you went the path with the bone anchors because you wanted durability and dependability over time, and in such that the bone anchor was integrated biologically into the bone. Did you at that point give additional thought to the durability of the tethers at that point, or you were only had the choice of using what was available at that time?
Yeah, we really thought that we would want to create a tether that would last, forever. And we know, I mean, you've talked to a number of different people who say it's always going to break. Nothing lasts forever, and so forth. And we can talk about that in a little bit. But I think, some of the original ideas were to, have a set screw and a spike to go through a straight tether. And my response to that was, that is really going to damage that tether. And, that may not be the optimal scenario. So yes, we had a lot of interest in having a tether that would give you a maximal effect and would have the least chance for breakage long term. You may know this, that there's some constraints in, you know, availability of materials and what the FDA approves, and even the caliber of the tether. You know, 5 millimeters is something restricted. You can't just double the size to make it stronger without a whole new FDA process. So I do think a lot of people have this idea that we would like this to last a long time. I would like it to last a long time. I think there's a lot of opportunity there. I think we've had a very nice proof of concept. I think we have patient. I mean, I have a patient who has, you know, a thoracic tether and a lumbar tether in for more than 10 years, the longest follow-up, successful follow-up in the world. And she hasn't broken her tether. So she had some modulation of growth. She may have had additional modulation in the bone and in the disc over time. And maybe that tether now has a lot less force on it because her spine has gotten used to this new position. But I'm not in the camp that it's inevitable that every tether breaks, but I am in the camp that we can always do better. And I think we should always look for devices that may have greater longevity.
Was that patient your first patient?
It was.
Mm-hmm.
You want to hear the story?
I'd love to hear the story. What was her curve like, and what's her curve now,
So,
or outcomes?
I'll just go a little bit back behind that, you know, in 2001, we were ready, meaning we were ready to go to the FDA and do an FDA ID study. And Medtronic by that time had changed their mind and really didn't want to cannibalize their fusion market with a tether device, a non-fusion or fusionless thing. And so what they did is they, among many other things, is they just decided not to do an FDA study. And I continued to do the research and build on this for many years without knowing that they had decimated my intellectual property and patented my ideas under other people and really breached the agreement that we had to go forward. But I was still focused on my tethering system as being, you know, I thought it was the best system. It was the only system for a long period of time out there. By 2008, I sort of got, you know, maybe I'm slow on the uptake, but it took a long time to figure out what was really going on with this device development. And it's unfortunate, but I was getting work done in the meantime. But I had been so interested in my, you know, the progress of my own ideas that I hadn't really looked at other options. And by 2008, 2009, 2010, it was clear to me that my device had been buried by a $50 billion company. And that was going to be very hard to undo. So a patient came to me in 2010, and she was from another state, and they found their way to me. And the father was an anesthesiologist, the mother was a nurse, so they were initiated to medical decision-making. And they said, we would like you to do a tether on our daughter. And I kind of chuckled or laughed. I said, oh, that's awesome. I love your enthusiasm, but I've never done a tether. And they were shocked, and they said, wait a minute, we've read all your work, and we assume that you had success in all these animal models that you were doing the tether. And I said, no. And, you know, I told them a brief version of the story that I was sort of stuck. And so I thought, you know, we know enough. We've done exhaustive research in almost every area you could possibly do. And I said, you know, it's probably reasonable to consider doing a tether if we can get a tether device. And there was one that was in Europe, you know, the Genesis device. It had been used in Europe. It was FDA approved in this country, not for non-fusion or fusionless, but for lumbar fusion in adults. But it had the principles of it were there, you know, the basic, you know, a screw that had hydroxyapatite so it could attach to the bone, and a ligament tether that could provide you, and it seemed like a reasonable device. So it wasn't made for children. It was the screws weren't short enough for some of the vertebral bodies, so you had to cut them with a massive bolt cutter in surgery. The instrumentation was huge and bulky for open lumbar surgery, so we had to figure out how to get it through three. I think we started off with 4 portals in the beginning, but went to 3. But our first case, we had to figure out how to get this clunky thing to work safely in a child. So I talked this family through it. I wasn't looking, to do my first case, for the first patient, like putting a target on them. They came to me and we kind of talked through it. And they're still friends. I've treated their other daughter. They're a really nice family and very astute, and spent a lot of time, probably like you, considering all the options for their child, and it worked out very nicely.
That's a good story. Do you recall what her curve was like? How old she was at the time? What kind of correction you were able to get? Yeah,
so she was 12, and she was skeletally immature in the Risser 0-1 range. She might have been Risser 0 when we met, but 12 is about the age that you see Risser 1 appear. But it took us, we didn't instantaneously make this decision on the first visit, so it took a little bit of time. But she had 2 curves. Her lumbar curve was a little bit bigger, so it was somewhere in the 34-degree range, and her upper curve was maybe 32, 33. So almost matched. And you might say, well, those are kind of small curves. And the answer is yes, that was our goal in the beginning because we didn't know. So you can always sit, 20, hindsight is 2020. Like, you can look back now and say, what were you doing? Well, Randy Betts had a 10-year period of stapling patients and found that they didn't have much effect over 35 degrees. So we were a little bit concerned that a tether, we thought it might be better, but we didn't know if it would work in a 40 or 50 or 60-degree curve. So we thought, we would only treat patients who had a curve that maybe hadn't reached that 40-degree clear surgical, range, 40 to 50. But if you looked at their Sanders stage and their Risser sign, they had a 90 to 100% chance of getting there. So if they were amenable, and this was early on, if they were amenable to brace treatment, they got brace treatment. We weren't trying to, treat people operatively who could be treated non-operatively. But if they weren't going to wear a brace or try to brace and failed, wouldn't wear it, we thought that was reasonable to consider. So she had criteria using the Sanders staging and the Risser that she had a 90 to 100% chance of getting to a 40 to 50-degree curve. Therefore, we thought that the curve would be surgical at some point and it would be reasonable to get in early. And so we got reasonable correction of those curves and they modulated over time. And she has a very nice result, played collegiate rugby, tested those tethers quite a bit. We only treated curves under 40 degrees in our first 10 patients. And the reason we stopped doing that, there was many reasons, but one of them was that we found that the tether was very powerful and we didn't have to treat them that early. We also had 3 that overcorrected. So because they were so young and so flexible, we got good correction. And then with growth, they overcorrected, which means what you're doing is having the effect you want, but too much of that effect.
Right, absolutely.
So we thought we could move into a range that was more the clear surgical range. And this is, I think, where tethering really, took a foothold, is that if you were battling, bracing, so a non-operative treatment that could, definitively solve your problem versus a surgery, that's a really hard battle to win. But if you say, brace every child you can under 40, if the curve gets into that 40 to 60 range, we have an alternative to fusion. And that's really what we wanted from the beginning, is really can you have an effect, a good effect, on the progression of the curve and avoid a fusion? And that's, I think, really the ultimate goal.
Yes, I agree completely. How many, if you recall, can you recall how many VBT surgeries you've done? How many tethers? How many?
To date?
Yes.
I don't have an exact number, but it's probably 150. That may be patients. Some of them, we did a lot of, our first patient had 2 tethers, not a double tether next to each other, but a thoracic and a lumbar. So I don't know, it may be 200 tethers. And this is an interesting thing, because this is always a double-edged sword, is that people say, well, you don't have the numbers to prove this. But then they might also criticize you for doing too many before you really knew how it would work. So what we've done, not just for the 10 years of clinical treatment, but for more than 20 years, is to just be very systematic, careful, and not rush. And we didn't try to do 1 million patients. I do think that the Shrine in Philadelphia has had a much greater volume, but and I think that's really good. They have access to probably many more patients than a lot of centers, and they don't have the same hurdle for insurance approval. And we have battled insurance from the beginning, and I think that's it's been a really good effort to teach. You have to teach the insurance world what this is about, or you're never going to get it, to catch on. And so we were very careful. We were what we thought was very responsible. We weren't trying to do this in everything that came in and find out, that it didn't work for this and it didn't work for that. And so we had a very, I would say, a slow ramp up.
Right. Well, I find it pretty fascinating that you did, for the first VBT, both thoracic and lumbar, because it seems these days when more and more surgeons are getting into VBT, they're kind of dipping their toe in the water in terms of mainly a thoracic curve and not going into the lumbar initially, because it is a bigger surgery in terms of going through a mini open as opposed to thoracoscopic, right?
So it's not more invasive, and it may not be, bigger. We could argue that, but it is invasive to go into your chest, deflate your lung, and all that. It's a little different to make a mini open over the flank, but so it's always good to get facts out on the table about, where things started. Larry Lanke put the first tether in a human back in 2005, and he did 3 tethers. And those were juvenile idiopathic scoliosis patients. And they were done through an open procedure, a thoracotomy. And they got nice corrections, and they overcorrected because they were young. So that was a very nice proof of concept that you could push the spine in the right direction and modulate growth, but all the tethers had to come out because they overcorrected. So when I talk about doing the first successful endoscopic anterior vertebral tethering for adolescent idiopathic scoliosis, that's a lot of words,
right?
But that's a very accurate way of describing what we did in 2010. I wasn't trying to just do 1 case or 2 cases or whatever. We were trying to stick to the principles that we had looked at for 12 years, and we were looking at sort of moving things forward and not just dipping our toe in and then pulling it out, but building on that over time. Anyway, we weren't the first. Some people will say, "Well, you weren't the first one to do this," and I would only say, "Well, okay, that's fine," but I'm trying to be pretty specific about the first case that we did. Was endoscopic. It was 2 curves, and it was successful. And so I didn't really answer your question, but you asked me about my training at the Twin Cities, adults, kids, every kind of anterior surgery, posterior surgery, everything. That prepared me in some way to do anterior thoracic and anterior lumbar. There are a number of surgeons who would be very comfortable doing thoracic curves, endoscopic thoracic curves for fusion, things like that, but wouldn't be comfortable doing a lumbar surgery. And so I think some of them just didn't like the idea of doing a lumbar surgery. And I heard people tell me that it's dangerous, and, you know, what if you had to do a revision? And, you know, I've had 25 years of experience doing adult revision surgeries all over that are much more complex than what a tether might present. But when this patient came to me, you know, her lumbar curve was bigger. And just sticking to principles, you can, you know, correct a thoracic curve, you can correct a lumbar curve, you can modulate growth in both areas. And we were able to do that. You may know that a lot of surgeons started when they got into tethering with just doing thoracic curves. And this takes us into another area where, you know, if you only do thoracic curves, you know, solitary thoracic curves are probably 1/3 of all scoliosis. Another third has a thoracic curve and a lumbar curve. So kind of a, you know, a version of a double curve pattern, whether the thoracic is bigger or the lumbar is bigger, but 2 curves. And then there's a smattering in the other third of, you know, different types of curves. But if you only do thoracic curves, you better hope that they're all just thoracic curves. And if there's a lumbar curve that you ignore, you may find that it ruins your thoracic tether. And that's, you know, some of the published data shows that if you ignore the lumbar curve, you wind up with a problem. Semdani has hinted to me that, you know, for years they did just thoracic curves in very immature patients. And some of those patients had lumbar curves that they left alone. And as the patient grew and matured, the thoracic curve was well treated, but the lumbar curve became a problem. And not only was the lumbar curve now bigger and in a surgical range, but the patient was more mature. And so they've had to treat those lumbar curves at maturity, and they've done pretty well, is what Semdani has said. So I think that's a really good, you know, people have learned over time that you can treat lumbar curves and you can get them to, you know, behave. And sometimes you can even do that when they're a little more mature.
All right, and you just added another 50 questions to this interview.
You know, we could do a 24-hour marathon and just.
If I could backtrack to the endoscopic approach and the mini open approach, I guess. I'm a little confused because some surgeons feel that with the thoracoscopic approach, with the ribs in the way, the ribs kind of don't allow the surgeon to correct curves under 30 degrees. I've been told by other surgeons that once you go through the endoscopic approach, that there's a lot of scar tissue being produced, so it makes it virtually impossible to do the revisions if necessary. Can you shed some light on those topics for me?
So every patient is different, even so, you know, the thoracic spine is more rigid than the lumbar spine, flat out. And the suppleness or flexibility of the rib cage changes over your adolescence. So age 10, you have very narrow ribs and a very flexible rib cage. And age 10, you're like Gumby, you know, a lot of times. So your thoracic curve may correct from 50 to 10 on a bending film or a fulcrum bend. So, and your ribs are going to be really flexible. So that's a very different patient than a 12-year-old patient. Your ribs are still fairly thin. You have some flexibility to your thoracic cage, but your thoracic spine is, you know, getting a little bigger and a little bit more adult looking. By age 14, and you know, there's error bars around these years that I'm giving you, but around age 14, your ribs are almost doubling in size, you know, just looking at them on a chest x-ray. And they really start to make the chest a little bit more like an adult chest. And that stiffness to the thoracic cage, causes some change in the flexibility of the thoracic curve. By age 16, and certainly by age 18, you're getting a much more rigid thoracic cage. So the thing is, there are patients that will preserve some flexibility throughout that arc, but among each patient, they're much more flexible at 10 than 12, and 12 than 14. And so you're starting to lose things over time. So if somebody says the thoracic spine is a little more rigid, I'd say yes. And it's rigid more as time goes by, I would agree. But it's the flexibility, rigidity is unique to that patient. So we assess the flexibility of the thoracic curve, with a bending film and a fulcrum bend. And we also assess the flexibility of the ribs with a scoliometer when they bend forward. And then you do a modified Adams forward bending test where they bend 90 degrees to the right, keeping their feet planted. And you can get an idea how flexible their rib prominence is. So why is that important? Well, a lot of patients, want their rib prominence to improve. And you want to guide them, and give them good information about how flexible their rib, how big it is, how flexible it is, and how much you think it might correct if you correct their coronal deformity and get a little bit of derotation. So do the ribs get in your way? They're there. We make a very small 2 to 2.5 centimeter incision. We just make 3 incisions. We try to place them, middle and then upper and lower part of the curve. If you make a single skin incision, you can undermine the subcutaneous tissues and create an even longer intercostal incision to get into the chest. And you can use that to move around quite a bit because your trajectory is really important for getting, safely putting a screw in. If you make your incisions too small, you don't place them correctly, and you don't maximize your use of the deep tissues, you'll be fighting the chest. And so you'll be fighting the chest to get the screws in safely, to get them in where you want, and you might be fighting the chest to get the correction you want. I don't think the ribs, I think the ribs make the spine stiff to begin with. I don't think they change your ability to, tension the ligament. You get it in there and you can provide the right amount of force. I think the thing about the thoracic vertebra is they get thinner and thinner as you go up. And so when you get to T6 and T5, T5 is usually soft. You put almost any force on a screw, it's gonna try to plow. So the correction you get in the thoracic spine is always less because it's a stiffer part of the spine and the bone is not gonna let you do as much. So you have to take what you can kind of get. An older patient, a curve lower down, the bone is bigger, and T12 is almost universally really strong compared to T5. So you can work around the ribs, but I think the ribs during surgery are not the problem. It's that the ribs have created, the whole rib cage has changed or imparted a certain flexibility or stiffness to the spine. You just have to deal with.
With respect to possible future revisions, is there, I guess it's patient dependent in terms of how much scar tissue that particular patient produces. Is it difficult to do multiple revisions if required?
Yeah. So I'm sorry I didn't answer that the first time, but so most of my career I've done adult scoliosis surgery. And just so you know, that's the majority of that is revision surgery. So unbelievably complex, crazy things that have, with instrumentation in place for years, eroded through, dura, very crazy revisions. And you can deal with revisions, you just have to be ready for it. Doing an endoscopic revision, we haven't had to do a lot of them, but we've done some. And occasionally the lung will have some adhesions to the chest wall. You'd like not to have that, but you can address those. And occasionally it'll be stuck down on your instrumentation, but a lot of times you'll have the pleura reform over the instrumentation, and that's sort of a glistening, smooth surface that the lung is not attached to it, and you can get a revision done fairly safely. And I think you can do that in the thoracic spine and the lumbar spine. It's not as easy. I think it's always a good idea to plan and have contingencies. And I really like having an access surgeon. When we did our first case, you know, I always think through, you know, priorities and goals. And one of our top, well, our top 3 goals have always been safety, safety, safety. And I like doing approaches myself, but I really thought it would be a good idea to have an access surgeon. And so we've done for 10 years every surgery with an access surgeon because it's just one more level of safety. So our access surgeon now, you know, I'm at MGH. We've got a team of 3 surgeons. Dr. Grakow is my scoliosis partner with 25 years of experience. And then Dr. Lawler, we do all of these surgeries together. Dr. Lawler has a ton of experience in the chest, endoscopically with tumors and revision surgeries and things like that. So I would never say anything was easy or a cakewalk. I would say any revision surgery has unknowns, and some of those can be really daunting, but I don't think the revision surgery is, you know, impossible or so hard that you can't, you know, achieve something when you do it.
Okay.
Good.
Very good. In terms of revisions, if you go back, I know in 2018 you were looking at perhaps overall maybe 3 or 4 tether ruptures. To date, is that the same number currently, or has there been additional ones?
So we're writing a 10-year paper that looks at, you know, probably 8 years of data, but 10 years of, you know, follow-up. So you have to have 2 years follow-up. And our tether rupture rate is around 12%. And it's very interesting. Some people have, you know, sort of, I don't know if they've scolded me or have impugned my ethics or whatever, but they said either I'm not looking to see the tether ruptures or I'm not reporting honestly, but, you know, whatever. We have not had any tether ruptures in the thoracic spine, 0. Now that doesn't mean we haven't had tether ruptures, but all of our tether ruptures have been thoracolumbar. So really between T12 and L3. So we haven't had to go back into the thoracic spine for tether rupture. We did go back for, you know, overcorrection and removal. So that's been a smaller part of our issue. Tether rupture is a really complex discussion, and it's something that I don't mind having this discussion. I'm working with, you know, Dan Hornschmeyer, you've interviewed him. Mm-hmm. So we're working together on, you know, a tether rupture study. Sorry, my phone made a noise there. Really to try to better understand this. But I think early on, the cord may have not been used appropriately by everybody. So there's a central portion of the cord that is made for implantation. And then there are these ends that have blue hatch marks on them. And some people didn't know which part of the cord was, you know, medical grade for implantation. So that's potentially number 1. Number 2 is people damaged the cord when they put it in. So they wrapped it in a vice grip or grabbed it, which can damage something that's made of, you know, basically polyethylene, like a climbing rope. The next thing is some surgeons, when they're correcting, you know, you have the ligament goes between 2 screws and it's already attached here, but you might squeeze these together and tighten the set screw. And then you might look and say, I think I can get a little bit more. And so you loosen the set screw and you squeeze it some more, and then you retighten it. Well, now you've damaged the ligament in 2 places instead of 1. And some people have done a lot of that. We never did that. Not because we're smart, I don't know, we just didn't do that. But I think we were very gentle with the cord or the ligament or the tether. Fortunately, the new system has less of a point on the set screw, so it may not cause the same, you know, damage to the ligament. But I think if you don't respect that ligament when it's going in, you might set up a cascade of wear and tear that you could have avoided otherwise. Now there's more. I do think that if you get all of your screws in a nice arc, a nice gentle arc, that may put less pressure on the cord. If you have screws that are kind of all different angles, the cord may be doing something that isn't biomechanically as friendly. And so you may speed up the degenerative process. And there's a third thing that I don't really know, that my surgery does differ from everybody else out there, is that I've never used that staple. You know, the washer that has the prongs on it that you put the screw through. So people have said, well, we really like that because it gives you better fixation and the screw doesn't plow. And outside of very weak bone at T5, we haven't had any plow either. But I've never used that staple. And so there's a possibility that my screws are less rigid right at that edge of the bone where the anchor is. And so when you talk about forces on the ligament, there's a differential, right? It's a differential between how stiff the screw is and how flexible the ligament is. If the screw has even just a tiny bit of micro give to it, it might protect the ligament, just like the give in the ligament protects the screw. So I don't really know if the staple is contributing to this tether rupture, but we don't have any tether ruptures in the thoracic spine. We just don't. And I've looked. I presented a paper on that, I went back and measured every single pair of screws to try to see if I was missing something. There's also been a comment, well, maybe the tether has ruptured and you can't see it because the spine didn't, you know, go back, you know, the curve didn't come back. And then I'd say, yes, if that happened, then that supports my theory of the spine modulating over time and getting used to the new position and putting less and less pressure on the tether over time. So that even if the tether ruptures, the deformity doesn't come back.
Well, let's go down that rabbit hole a little bit in terms of the more mature spines, because there's, as you know, the whole concept of VBT is to take advantage of bone growth modulation as the spine matures, and there is a bit of controversy in terms of tethering more mature spines. The idea being, well, if the tether fails, there's no bone growth modulation at that point. So how does the curve stay stable instead of returning to the original curve? What have you seen that contradicts that?
I like to start off my answers to these types of questions by saying, you know, I don't really know. I don't have all the answers, right? So I'm not going to be able to tell you absolutes, but what I try to think of is like the big center of the target is growth modulation. We started that way back in the late 90s saying we would, and I didn't start it, you know, Ian Stokes was the one who showed in a rat tail that you could create and correct vertebral wedge deformities according to the Hero-Volkmann law. That was really nice in a rat tail, and all we did was try to do that in a bigger, you know, animal with a different type of device. But you know, the idea of growth modulation is really attractive. It has great basic science, warm and fuzzy feel to it, all that. And I'm still going to say that that's the center of the target. That's a really great target. And that's where we started. And, you know, we had to convince a lot of people to have any interest in this. And so, you know, that was a really good thing to, you know, use basic science and to use something that a lot of people thought would be, you know, really attractive to try to manipulate, you know, that Hero-Volkmann principle that was driving a curve to get bigger, to harness that growth, redirect it, and make the curve straighter. So no argument that you know, modulating growth is a really great central portion of the target. And I would say in children with idiopathic scoliosis, your ideal candidates are going to have, you know, growth, curves in a certain range and a certain amount of growth. but that's not every patient. So, there's more of the target, right? So I don't think I'm crazy. I'm interested in helping patients with their spinal deformity. And not all of them come in with the perfect curve and the perfect amount of growth. And sometimes, there is an advantage to avoiding fusion, even if you can't modulate growth. So the center of the target is, modulating growth, and that would be an ideal candidate. But there are acceptable things kind of on the outer rim of that target. And you can still potentially give a patient a really good outcome, even if you don't have a lot of growth to modulate. And you might laugh at that and say, well, show me the data. And I'd say, okay, it's coming, but other people are learning this slowly. And I didn't know that this would work for sure, but the first patient that made us think of this was a patient with a curve further down, like a thoracolumbar lumbar curve. And the curve had progressed, 50, 55 degree range. And there wasn't much growth, but it was flexible enough that you could get good correction at the time of surgery. So if you can take a curve in the severe range, which is over 40 to 50, and you could put it in the mild range, which is 25 or less, why isn't that a good outcome? Now, Peter Newton would say, well, because it's going to fail and you're going to hurt the child and it's all, it's going to be a disaster. And I'd say, well, it hasn't been. We have been able to take curves, in that 40 to 60 degree range, but slightly more mature, sometimes toward the end of maturity, and get a nice correction. And that correction has been, durable over time. Now, why is it durable? And I'm not talking about treating 50-year-olds with scoliosis. That's a whole different topic we could chat about if you want. But I'm really talking about patients who have come to the end of their adolescence, right? And meet certain criteria. So if you don't have the growth, you have to have some other things that make you a reasonable candidate for tethering. And you have to develop a risk-benefit equation where you say, okay, it's more reasonable for this patient to have a tether and try to avoid a lumbar fusion. And that's a complex thing that the patient, the family, and you develop that equation. It's not the same for everybody. But so what we think is that if you can get the curve to a reasonable contour and you can hold it there for a decent amount of time, that probably there will be some remodeling along the lines of force. Your hip does that, your knee does that, your whole body does that, in your bones and in your tissues your whole life. Huter-Volkmann is a great center of the target. It's only the growth plate. Even in the patients that you think you're modulating growth, you're modulating the vertebra in between the growth plates. By Wolff's law, you may be modulating the end plates, which may respond, bone drift. They may respond to a different law that nobody's named yet. And then there's a whole area of modulation of soft tissues in the disc and around the disc, in the ligaments. So just because we got fixated on growth modulation and Huter-Volkmann, that's not the whole world of the spine or modulation over time. So we think that if you went in, put a tether in somebody and corrected, and 1 week later you took out the tether, the whole curve would come back. You wouldn't have had time for anything. And this is a slightly more mature patient, right? So if you have the tether in for 2 years, you could probably take the tether out and the curve would partly come back. Now, you may not be able to make a strong argument that you modulated the bone growth, but maybe a lot of that curve was in the discs anyway. It's a big part of the equation. If you held a patient for 5 years, 5 years is a long time, okay? Their bones have remodeled along the lines of force. The force here, and with a bigger curve, is outside of the vertebra, right? It's really squeezing the concavity of the vertebral body. When you get it into a reasonable range, the force is hopefully going more centrally through the vertebra. Maybe not perfectly in the center, but I think you're modulating things over time. So my hunch is, and I don't have data yet for this, is that if you could hold the spine in a position for a long period of time, and then you took the tether out, say after 5 years, you probably wouldn't have much of the curve come back. We have some of those patients who have had little tether ruptures, 2, 3, 4, and 5 years out, and the average loss of correction is 14 degrees. It's not catastrophic.
Absolutely.
It's not terrible. And it's not like a ticking time bomb where the patient explodes and has a terrible outcome. It's asymptomatic. They don't know it. You measure it on an X-ray at a routine follow-up, and there hasn't been a huge detrimental outcome to our tether ruptures. So we had one tether rupture that occurred day 2 after surgery, which was my fault, over tightening a set screw, the old set screw, and the torque device just didn't, we went past probably what we should have and crushed the ligament. I revised that patient and only one other patient for a tether rupture. The other patient I revised was 2 years out, and the mother was a radiology technician and said the child had no symptoms, but the mother said, "It's broken, fix it. We need to fix it." So that's our obligation, I think, if they feel they want it done. So we did it, and we got whatever loss of correction we got back, but we haven't had to revise a lot of these patients. So we try to have a very careful conversation with patients about their options, fusion versus tether, and we talk about what's out there in the literature and our experience about overcorrection and tether rupture, and somewhere around 12% tether rupture. We don't like that, but it hasn't been profoundly detrimental to how the patient does. So
I understand. Dr. Braun, we're over about 5 minutes. Do you have a few more minutes, or do you have to run?
I'm free.
Are you? Okay.
I don't want to torture you, but
No, are you kidding? No, and the viewers of these, they love the details that I'm asking you, because again, we hear different opinions from different surgeons. So it's great to hear your information for sure, especially with your basic science research. Now, you mentioned before that for more of a mature spine, if you get it within a certain correction, you have a good feeling that it's going to hold. Does that have to be, is there a magic number? Does it have to be less than 25 degrees? Does it have to be less than 30? What would you say to that?
Again, remember my answer, I don't really know. I can tell you what I think, and I'm not going to try to fool you that I have all the answers, but there's some numbers that have meaning, and they probably are a little bit different in every patient and every curve and so forth. But we don't surgically treat curves that are over 40. So if you can get a curve under 40, that's probably putting it back into a range that you wouldn't have treated surgically. But I still think 39 is a pretty high number. So, Peter Newton has come out with 35 degrees as a good target. And I think that's because 35 is, there's a 5-degree error in measurements. So that's a decent amount below 40. And I like 35. And then I think Dan Harchmeyer has come out with 30. And, you could pick 25 or 29 or 31 and a half and whatever. But I think some of it matters, that if you can get the curve into a milder range. And really, I love 25 as a target, but it's not absolutely necessary for a good or excellent outcome. I do think some of the papers, because these are retrospective studies and so forth, they've focused on radiographic outcomes for, determining success. Did you get to 25 or 30 or 35 or whatever? I've had patients with, not awesome correction who were really, really clear that they wanted to tether. And they're some of my happiest patients, very smart people who may not have gotten as much correction as others. I do think when you talk to patients ahead of time, you have to really figure out what they want. And this is key. They don't necessarily care. Their moms do about the radiographic number because that's what goes on Facebook. But the child may care about a shoulder, they may care about the rib prominence or a lumbar prominence or a trunk shift. Some of them are very focused on a sport. They're a high-level athlete and they just want to be able to get back to that and stop messing around with a brace or other treatments. But I do think that pure radiographic outcome it's important that you don't have a good correction and then lose it, because that's going to tell you that you may have a failure down the road. But I don't know that I can come up with a pure number at this time.
Okay.
I did want to say something else though, that like, you know, when you treat growing patients that have, you know, growth that you can modulate, you're probably going to have more flexible curves and get better correction. The mature patients, you're probably going to get them where they're going to be on the day of surgery. And I think you still ought to have some idea what the target is, what a good target is. And so I think 30 plus or minus 5 is probably a nice range. I think you're going to find that the majority of patients that sort of get into that 25 to 35 degree range are going to do pretty well. That's the center of the bell curve. You may have some patients above that still do just fine. And a curve above that in a stiffer thoracic spine might be more protected than a really flexible curve that's bigger than that in the lumbar spine. But there's also going to be those patients, those lucky patients that, you know, you get them from 50 to 20 and then they correct over time and they have an almost perfectly straight spine and they're done with their growth and they don't overcorrect. That's a home run. That's a grand slam. I just wanted to make a point, and I'm sorry if I'm babbling on about this, but the more mature adolescent is a little bit different than the adult. And this has come up. I got accused by a bunch of people who didn't really understand what I was doing, that because I presented a paper 4 years ago on more mature versus less mature adolescent idiopathic scoliosis patients. And somehow people got them understanding that I was treating 50-year-olds with scoliosis.
Right.
Adult scoliosis is profoundly different than idiopathic scoliosis in children. And you know, to distill it down to maybe one simple way of thinking of it is that in an adolescent, you're kind of treating one thing. It's the deformity. You may have some other subtle diagnoses and things, but you know, there's usually not a massive component of pain, degenerative change, spinal stenosis, facet arthropathy, you know, rotatory instability, you know, ulcer spondylolisthesia. You know, you can have an adult that has 10 diagnoses with their scoliosis. And I think what you have to be really careful about is what drives a patient and their family to seek treatment during adolescence is usually the curve and the curve progressing. It may be a very different psychology that brings an adult to treatment, because they may have known about the curve earlier. And if they didn't know about it, maybe it was neglected. If they did know about it, they may have chosen not to do anything for the deformity itself. And what may drive them is the deformity gets bigger, causes pain, causes other problems. And so it isn't as simple as just treating the deformity. You have all these other things that are problematic. And you may know this, but the best way not to have pain after scoliosis surgery is not to have pain before. That's a predictor of a good outcome, is you didn't have pain before and you're very likely not going to have pain after as an adolescent. But if you have pain as an adult, a lot of pain, a lot of different types of pain and degenerative changes and all sorts of things, you know, just using a flexible tether to put your spine in a different position may not solve the problem. If you have, you know, the most typical pain in an adolescent is pain on the outside of the curve, you know, along the convexity. And it's usually muscular pain. And it sometimes gets worse as the curve gets bigger because the asymmetry in the muscles. And if you can take that curve and make it straighter, you can sometimes balance that out where the pain disappears. that's only one type of pain. That's the easiest type of pain to, make better. Not every adolescent has that type of pain. And we actually feel that if you have atypical pain, severe pain, that, that makes you less of an ideal candidate for a tether. But in an adult, it's a whole different world. And the only thing is, I'm not going to, draw a line in the sand and say there's no role for this in adults. But I would say you really have to understand how complex adults are. You may not just be treating the deformity. There's a lot of other complex things in there.
Sounds reasonable. You're dealing with one variable as opposed to about 10 different variables in a mature spine. Question for you is potentially, yeah. A question for you is that some surgeons, in terms of when they're treating more mature spines, are trying to get near zero corrections, and they are doing various forms of disc release or anterior release to try and reduce the anterior column, derotate, and get as straight as possible. Do you have a perspective on that?
I do. So, and again, starting off with, I don't have all the answers. I don't really know. I've, done a lot of anterior fusions and taken a lot of discs out and so forth. But I've also, seen what degenerative discs can do, long term. One of the things that, remember where we started with tethering, the whole, or trying to avoid fusion, that patient that had an adjacent segment problem in a disc. So we really, really want to respect the disc, and we really want to have a treatment that corrects scoliosis, controls it over time, but preserves the health of the spine and the function of the spine. And I don't want to be too rigid about a philosophy, but cutting into the disc, to me, potentially causes a problem. The disc is a kind of a delicate structure, and what you don't want to do is start a cascade of degeneration, and you don't really know the outcome. We did a bunch of work looking at the effect of a variety of different fusionless scoliosis implants on the disc health. We started some of this way back in 2001, 2002, looking at regional biochemistry of the disc and histologic changes. And we did another study years later that we won the Hibbs Award for at the Scoliosis Research Society. But we were really interested in the health of the disc just from putting these implants in. So they changed the biomechanics of the spine to some degree, and we were worried that might negatively impact the disc. Turns out doesn't have a huge negative impact, but it might have some. If you start cutting into the disc, damaging the viscoelastic, function of that disc, damaging the collagen, potentially, ruining the integrity of the, proteoglycan and all that. I mean, you don't really know what you're doing, even though you think it's important to get a straighter spine. I'm not sure that trade-off is worth it. I think you're poking a snake, and you might get bitten. And I have a patient that has now come to me who had one of these surgeries in her 40s, and she had two curves that were almost perfectly straightened out with disc releases and some other things. And she had about 6 months of pain relief, and now she's miserable. And I don't know exactly what to blame it on. We're still working some things up, but that's the worry, is that if you have a disc and you have abnormal biomechanics across that disc, and that disc does not have the integrity it once had, it just may not be able to hold up over time. And lumbar discs wear out and cause a lot of pain. I did hear Randy Betts saying that nobody does thoracic fusions for degenerative thoracic discs. And I'm going to say, yeah, because it's not an acceptable thing. But if you create a huge amount of thoracic back pain, it doesn't mean that patient is happy. I mean, they're still miserable. It's just that somebody may not want to do a disc surgery for their pain. There are definitely patients that get degeneration in their thoracic discs and get pain. It's less common than the lumbar spine because the lumbar spine has more force the further you go down and more motion and tends to get more wear and tear than a lot of thoracic discs. But the answer would be that I think the jury's out on that. But my sense would be that the whole goal of doing this was to preserve the spine as much as possible. And if you don't have a curve that's amenable to that, maybe a fusion is a better option. Sorry, I mean, we still do at least half of our surgeries are fusions, but I think, just trying to get better correction so the x-ray looks better, that may be a little too much emphasis on the radiographic result. And
well, one argument I hear for doing disc release is that with severe curves, the disc is already pretty. Some surgeons say the discs are very degenerated anyway. They're quite fibrotic. So if you have the choice between a better correction and disc releasing those fibrotic discs, is there a real trade-off there in the end?
Well, if somebody's standing on the edge of the cliff and you push them off the cliff, there's a difference. So I think if you have a large thoracic curve and you have very degenerative discs, that is almost begging you for a fusion. And I don't mean to be a nihilist and saying, oh, no other options, knee jerk, do a fusion. But, and especially if the patient has pain, because preserving motion in somebody who has pain, that motion across a degenerative disc may all by itself cause, you're not creating normal biomechanics with a tether. You're changing it. You're just hoping that in this young patient, their disc is healthy enough to adjust to it. So, I have this analogy that I've used with patients for years because I always try to have a balanced discussion of fusion versus tether. But, the thoracic spine does not have as much motion as the lumbar spine. If you do a fusion in the thoracic spine, you lose something, but you may not lose as much as you think you're going to lose. So the analogy is you have $1 in the bank goes belly up, you lost your dollar, okay? You lost something, but you just didn't lose that much. If you do a lumbar fusion, you lose a lot. That's like having $1 million in the bank and the bank goes belly up. So I think there are different parts of the spine where, fusion versus tether, there's a different equation. And, we do have some patients that, have a thoracic curve that is really most appropriate to treat with a fusion, like a selective thoracic fusion, but they also have a lumbar curve. And you can, balance your treatment by saying, look, you're going to do better if we do a fusion up here. You get better correction and we'll get rid of, yes, you'll sacrifice your motion, but you'll have less chance of having pain up there than if we try to use this sport model tether to sort of get your spine in a better position. But do a correction up here, which is going to help improve the lumbar curve, and then do a tether in the lumbar curve. And if you had an adult, I'll just make up, let's say you had a 30 or 40-year-old athlete who had two big curves as an adult. And again, I'm not telling you, I don't operate on that patient with a tether, but I have had people ask me, maybe instead of doing a thoracic tether and a lumbar tether, maybe doing a thoracic fusion, a selective thoracic fusion in that patient, and saying, look, instead of taking away all your lumbar motion, we'll do a lumbar tether. It may not last forever, but you can still do your, triathlons or mountain climbing or whatever. And when that fails or breaks down, maybe we'll have to do a fusion down the road, but buy that person who's very active, maybe an athlete, buy them some time. And again, I'm not advocating for that. I'm just saying that maybe that's a more reasonable way to go.
Fair enough. Just two more questions, sorry to keep you so long. One question I had is with respect to immature spines and tethering. Now, I guess when I started doing these interviews about 6 or 7 months ago, um, surgeons were telling me they were looking at hopefully about a 50% correction on first standing X-ray. And they were hoping for maybe 20–25% passive correction after that through growth over the next 2 or 3 years. There's been a little bit more research coming out lately that first standing X-ray kind of seems to be what the curves are settling out to be over a couple of years. Are you finding that to be the case as well?
So you have really good questions. It's a loaded question. The first erect I don't like, because very often the patient is in pain. And I'm just going to give you an example that if we do 2 tethers, thoracic and lumbar, this one doesn't hurt very much. This one hurts more. So you said it was a bigger surgery. It hurts more because you're cutting through the abdominal wall. But our first erect in those patients is really interesting. It looks like a question mark, because what happens is they lean to the left to protect their muscles that you cut through. And so the lumbar curve actually looks a lot straighter. It's more flexible, and they actually bend it so that it's almost perfectly straight. That's the bottom of the question mark. The thoracic curve, remember, these curves are still flexible. They're not fixed in time like with a fusion. So the thoracic curve actually bends more. And so, you know, maybe the first time we did this years ago, we freaked out and said, oh my gosh, like we got too much correction down below and you have this, right? And what happens is as they recover from the surgery and they balance out, their lumbar curve settles into a more reasonable position, and the thoracic curve, you know, and it's not the thoracic curve improving and the lumbar curve, you know, progressing. It's just that you have an artificial way of measuring that with the first erect film. So I don't like the first erect film. It's got, you know, surgical issues and pain and stuff associated with it. We think that by 6 weeks, sometimes 12 weeks, you're starting to balance out. The pain is gone. You do have some cerebellar or, you know, brain issues where you're actually, your body starts to balance itself out. I don't think the body does, it does some of that with a fusion, but it's harder for your body to understand the, you know, profoundly abnormal biomechanics of a fusion. And it's a little bit easier with a tether because it can still move the vertebra and the discs within the segment. So how much correction do you get? So this is, it's a question with a lot of variables. So there's no one answer. The first thing is, how big is the curve and how flexible is the curve? If there's a 40-degree curve that corrects to 10 degrees on a bend or a fulcrum bend, 40 degrees is tiny, and correcting to 10 degrees is really flexible. And if that patient is 10, 11, or 12, you could correct that way more than 50% at the time of surgery. If you have a 55-degree curve in somebody that's still growing, but let's say Risser 2 and age 14, a thoracic curve, 55-degree curve, let's say it only bends down to 30. Well, you're never going to get that curve to 10 or 15 or 20. Mm-hmm. And there's a lot less growth to get subsequent, you know, correction. So, you know, we have patients with 50-something degree curves who really have stiff curves. They only bend to 40 or 45. And maybe that's not a great, you know, candidate for a tether. So how much correction you get is, you know, percentage-wise is dependent on how big the curve is and how flexible it is. And there are proxies in there of, you know, how young is the patient, how much growth do they have. There's a technique component of, you know, you could have a very flexible curve and just not get the correction you wanted because you didn't push the system, or maybe the bone was soft. But there are other factors that may change how much correction you can get. But in our 10 years, we, for all comers, and this is younger and more mature, we probably have about 40% correction, 40 to 50 range for thoracic curves. And we probably have, so slightly under 50. And for thoracolumbar and lumbar curves, we have slightly more than 50. So I'd say 40 to 50 from just a broad brush for thoracic curves, 50 to 60% correction for a lumbar curve. The younger you are and the more growth you have, the younger you are and more flexible, the more correction we're going to get at time 0. And the more growth you have, the more correction you're going to get over time. We actually did a study of this in an animal model. And we looked at 2 types of correction: active by the surgeon at the time of surgery, and passive with growth over time. And we compared 2 staples, 3 staples, because that was clinically relevant to what Betts was doing. And then we matched that with a ligament that we tensioned to match the compression of 2 staples, called that a submaximally tensioned ligament. And then a maximally tensioned ligament, we tried to match the 3 staples. And what we were trying to show is how much correction we could get initially and what that did to the subsequent correction with growth over time. And we moved away from our scoliosis animal model to a straight spine. And we found that if you didn't get a lot of correction in surgery at time 0, you didn't get a lot of additional improvement over time. You really need to make a change in the biomechanics to have an effect. And and the tether did really well. Whatever you got with the tether, you got about 50% more with growth. So your numbers are actually interestingly aligned with an animal study we did we presented at the Scoliosis Research Society in 2007, where we got whatever we got at time 0, we got about 50% more over time. And so if we could create a 30-degree curve by the end of and this is just an animal model where we artificially selected time periods, but we got about 50% more. So, more curve out to about 45 degrees. So those 2 are related. You have to be careful though, and this, that, if you really target all these Risser 0 patients with open triradiate cartilages and you get a huge amount of correction, the dynamic correction you have can have an exponential effect on growth. It's not as if it's linear and they just gently fall back into the right range. You must have read this study, but we did an animal study where we compared static and dynamic modulation of growth. And there was 50% more change with dynamism, which is, why a tether would potentially work better at that than a staple.
Or plate or something used for sure.
Right.
Okay. Sorry. If we can backtrack a little bit to the tether, and perhaps we talked initially about material science a little bit. Do you know of any advances to tethers that are going to be coming out in the future?
I wish I did.
That was a quick question.
So I do know people have an interest in that. I mean, we'd all be idiotic if we said, we only wanted, a hip replacement or a knee replacement for the last 2 years. I mean, everybody's always working on, longevity of implants. So I do think one of the initial things is, could you change the material? Yes, potentially. But there are FDA hurdles. You have to go through, is the material safe? Is it going to cause wear debris that could cause, tissue reactions or cancers or, get in the bloodstream and things like that. So you can't just switch to another material without a lot of work. You could potentially take the material that you have and make it bigger, protect it, do other things that make it last, less damage to it, things like that. Things that sit in the body environment, you don't know if some of the fluids in there, cause oxidation or cause things to, wear out faster over time. Oxidation, that's what, rust and, we all take antioxidants so that we live longer. I mean, oxidation isn't perfect for humans or sometimes devices, but, there's a lot of things that you could do to potentially take what you already have and, give it more longevity, protect it. I would love it. I mean, the ideas of like, what if you had a device that, would shrink over time so that it would add, you know, it would slowly, contract and give you more correction over time. That's safe. It kind of does what maybe growth isn't doing. What if you had a magnetically controlled or, radio controlled implant that could, I mean, that's very high tech, and it's not like there's enough space to do that at this point. But, 10 or 20 years down the road, there may be ways of doing things that you could implant and then from the outside tweak and manage things, without having to go back in.
Segmental tensioning would be amazing, wouldn't it?
There's another thing that we did a study years ago where we looked at the molecular signals. So in your growth plate, there's all these chondrocytes, the cartilage cells that are telling each other what to do, and they're telling each other to, make more of ourselves and get bigger, and then when to die, and how big they get and how many are made determine how much the growth plate grows, right? So how much the growth plate grows determines wedging. And we thought we could figure this out. This is you have to have a PhD and a whole career to do this, but we thought we could figure out some of these molecular signals that maybe we'd get lucky. Remember this lucky thing? Like, we're just going to ask the question and see. And we found a few things, that some molecular signals that, may have influenced, the extracellular matrix and how big these cells got and so forth. And we thought, wouldn't it be great if eventually you could have like a miracle growth spike? Like, forget all these brutal orthopedic biomechanics things that we do. Like we, put big anchors in and we squeeze them together. I mean, that's kind of a caveman approach if you think about cellular manipulation. So, if you took a miracle grow and stuck it in the ground next to your, a plant or a tree, you would hope that the tree would, respond to that favorably. And in the spine, you have two sides. You have one side that's growing too much and one side that's growing too little. And if you could understand the cellular mechanisms, you could potentially manipulate those without having to have a mechanical solution. So
yeah, that would be amazing.
Yeah. So there's a lot of things that are out there that you could do. You have to make sure you don't get too excited about everything 3 steps down the road, and you still make sure that each step you take forward is solid, and that you work with what you have and you try to deliver a better treatment. But there's tons of room for improvement.
Okay. Final question. I wanted to go back to the water cooler talk you had with Dr. Samdani in terms of him noticing.
It was actually in the bathroom, but
okay. I didn't want to bring that up anyway.
Yeah.
And with him kind of, because he was pretty conservative in terms of looking at purely immature spines, right? And he's now considering perhaps looking at tethering a little bit more mature, again, moving from the center of the target to a little bit more to the edges.
Yeah.
What do you think influenced him into his new way of considering more mature spines?
So I think he's like a lot of people that are involved in this. There's a lot of good minds that have, gotten involved in this. And I really like Amir Samdani. I think he's a very thoughtful, and you interviewed him. He's a very genuine person, and really, he really cares for his patients. And, so is Peter Newton, and so is Dan Hornschmeyer. And there's a lot of good people in these areas. But I think Amir really wants to do the right thing for his patients. And there's always a tension in that of what you know and what you don't know. And so I could be accused of doing, a crazy surgery on a patient 10 years ago because of what we didn't know, right? But the tension is, I thought we knew enough. We had worked out the safety and efficacy in animals in preclinical testing, and I thought it was a very reasonable thing to go ahead. And you learn as you go, but it's not experimentation. You have enough knowledge that you can do the right thing for this patient or give them an advantage potentially over fusion or a more standard treatment, but there's always a tension of how much you know and how much you don't know. And I think all of us struggle with, you know, the ethics of that and how responsible you have to be, you know, for pushing the field forward, but also, you know, appropriately caring for each patient. And I think Samdani is, you know, was very convinced that this was probably a thoracic treatment. It was endoscopic, and they had been doing a lot of stapling, and they had done a few, I think, lumbar staplings, but they really thought that this was more of a thoracic treatment. And I think what he learned over time is some of those patients who had lumbar curves, you know, if your lumbar curve is untreated, let's say you have a thoracic and a lumbar curve, you correct this thoracic curve with a tether, but the lumbar curve is still getting bigger, it will make your thoracic curve bigger. It'll put more stress on that tether. And so I think he probably got the idea that some of his treatments were being threatened by this lumbar curve that, you know, was maybe not taken as seriously as he would have liked to. So then I think he said, well, you know, if a patient really liked the idea of a tether and you tethered their thoracic spine and they came back with a big lumbar curve, they're really not going to like the idea of a lumbar fusion, right? That would be just like upside down. You know, you tether the thoracic spine and then you fuse. So I think he saw that as an opportunity to sort of, you know, get them back into a balanced spinal position and control the lumbar curve. I don't know his data in the lumbar spine, but, you know, he did kind of, you know, whisper to me that some of these lumbar curves did pretty well, even, you know, at maturity. And, you know, it's not perfect. You know, more mature patients are harder, but I mean, you don't get as much correction and you can't rely on growth. And they may have a slightly increased risk, I think, in our series of tether rupture, but they have fewer complications overall.
Okay.
But anyway, I would end that by saying, I certainly do not have all the answers. All I know is that we've been very systematic and just done brick by brick to move things forward. I think a lot of people don't know all of our data. You know, even some of our, you know, basic science stuff we presented at SRS maybe didn't publish yet. So people don't maybe have all the information we have, but there's a lot of people out there trying to do very good things and are moving the science forward. Some of them just have a very different background than we've had, you know, over the years. So
very good. Dr. Braun, thank you so much. This is a super extended interview.
I'm sorry for babbling on there, but
no.
It is a topic I enjoy talking about.
And I enjoy listening to you. Thank you so much, and take care. Have a great day, and hopefully we'll follow up in maybe in a couple of years to see what's up.
That'd be great.
All right.
All right.
Thank you very much.
Thanks again, Derek. Bye-bye.
Bye-bye.